warm welcome to Let's Talk About Health. We are live on Facebook and YouTube. 2 weeks ago, I had a guest with me and we had a patient account on how she has actually recovered as a breast cancer patient after having all sorts of treatment. And if Mrs. Harriet Brown Insoa is watching, I want to take this opportunity to say a very big thank you to you for the awesome account and how much encouragement you've given to people who may be suffering in silence for one diagnosis or the other. I know you are watching, so thank you, big sis Harriet Insoa. Tonight we will be taking a look at major obstetric hemorrhage. And about a month ago, we actually looked into all the causes and highlighted the causes of maternal morbidity and mortality with Ghana in focus. But before we go into tonight's show, let's take an advert. We will be right back. I'm your host, I'm Mrs. Winnie Ohinikisi.
What I can say about Chris is he's very hardworking, he's meticulous, very detail-minded. He likes to think outside the box. You leave a work to Chris and you are sure you'll come back to meet your best. And we were working together nicely before he had this intention of starting his own business. He discussed it with me and I endorsed it and I let him go. And ever since I've been working with him, I disposed a couple of properties. I did it through him, and that was done in a record time. And I will always recommend Chris for anyone who wants to deal with properties, to deal with Chris and have the peace of mind and also have assurance that he will have the best deal.
At World Remit, we understand what the journey is about, how it can sometimes take a little distance to bring us a little closer together. With ways to save more when you send more, World Remit is here for you, so you can be there for them.
Hello, welcome back. Thanks for joining us on Facebook and YouTube. Again, I must say that I'm happy to have the Trowbridge Foundation with us. And we looked at the causes of maternal mortality and morbidity about a month ago. So we promised to take a look at the individual causes, and that is what we are going to do today. So I think we are going to focus on major obstetric hemorrhage and then preeclampsia. I'm sure a lot of people will probably be familiar with preeclampsia, eclampsia, but major obstetric hemorrhage probably will be known differently to most people. So what exactly is it?
Thanks for having us.
Yeah.
When we mention major obstetric hemorrhage, I mean, what we're talking about is a woman who, during her pregnancy or at the time of childbirth or soon after having the baby, bleeds quite significantly, enough for her body system to start to have effect. So it is very common. It is worldwide. I mean, pregnancy itself, where the baby lies in the uterus, is filled with blood. So you would expect some degree of bleeding at the time of childbirth.
Okay.
And potentially soon after. But by and large, these bleeds are not huge enough to cause any effect on the mother. So when we talk about a major obstetric hemorrhage, we're talking about that excess amount of bleeding, which is such that if it's not managed properly, can potentially kill the mother. It's not only during childbirth or soon after, but during pregnancy itself, there are situations where women can bleed quite significantly, even when the baby is still inside. We do know that in this country, for instance, if 1,000 women had a baby or got pregnant, potentially three or four of them will unfortunately lose their lives. So it is not something which is unique to Ghana. Okay. Unfortunately, the maternal mortality rates in relation to hemorrhage, or what people commonly put it as postpartum hemorrhage, is quite significantly high, and if anything is probably one of the leading causes of maternal death in Ghana, and of course maternal mortality, because if you bleed a lot and everything goes well and you lose your life, it has its consequences as well. So when we talk about major obstetric hemorrhage, we are focusing on the amount of bleeding which is enough to affect the body organ systems. It is classified into three groups, and as I said, everyone is expected to bleed a little bit at some stage during childbirth and afterwards, because the baby has come out, the placenta has come out, so it will be followed with some bleeding. If you bleed anything up to about half a liter or 500 mils, by and large you'll be okay. We wouldn't have to do anything on you or transfuse you or anything like that. By and large you'll be okay. But it's when you start bleeding more than that. So when we talk about minor postpartum hemorrhage, for instance, what we're saying is, baby's out, you're bleeding, and you've bled anything between 500 mils or half a liter to a liter. Now that is quite a lot of blood, because you're talking about probably 2 pints of blood,
right,
or up to about 4 pints of blood. So we call it minor because it's quite manageable, between 500 to a liter. But there's also moderate postpartum hemorrhage, which also falls under the umbrella of major obstetric hemorrhage. This is when the woman loses anything between a liter to 2 liters. Wow. So that is becoming a lot more, isn't it? And then you've got severe hemorrhage, where the woman is just pouring blood and is losing more than 2 liters. So these are the three categories. Either of these categories, we need to know how to manage it. Because if you lose blood and you keep losing blood, at some stage, your body is not going to function properly. It's akin to having a car. A car will run when you've got fuel in it. A car will run when you've got engine oil in it. If there's a leak somewhere in the tank, you have to stop it, isn't it? Because it will get to a stage, there will be no fuel in the car and the car will stop. It's the same thing as the human body. If you bleed and you continue bleeding, your body is going to try and respond. Your body is going to try and make it up for. If you don't replace the blood, at some stage, the body systems will stop. So either way, we need to try and learn how to manage it. Now, the human body is very intelligent, or the woman's body is very intelligent. When a baby comes out, the womb contracts, and that contraction alone is able to feed back some blood into the body system. And that is why I said, if you lose anything up to about 500 mils, your body will cope. Because the womb, which is as big as that, with a full-term baby in it, has loads of blood in it. So once the baby comes out and the womb contracts, and that is usually naturally, it will contract. The contraction will encourage blood going back into your system. So you should be okay. when you lose anything up to about half a liter.
Right. So like you rightly said, it is not a problem that is like pertaining to Ghana or Africa, or it's a problem worldwide.
It is worldwide.
Yeah. So what are the causes then? What leads to this?
So we have 4 main causes. The biggest cause is tone. So the tone of the muscles. So somebody that's been in labour for a very long time, the muscles get very, very tired and exhausted, and they can't contract down, as Bright says, so effectively. It may be that we've used drugs in labour to cause the contractions to occur, and so once that is removed, suddenly the muscles go lax and they don't contract so well. Or you could have, if you think about a huge uterus, like we've just said, a big bag, and you've got, say, a twin mum who has had a very, very big uterus and having to contract right down again, that's also very difficult to do. So there's lots of different causes. They're the main ones. Sometimes if blood collects into the uterus as well, it can't contract because there's something there stopping it from contracting down. And sometimes the bladder, if you've got a full bladder, it pushes up on the uterus, stops that muscle from contracting down as well. So there's lots of other causes, but they're the main causes of tonal problems of the uterus. And that accounts for about 70–80% of all the bleeding that we have. Then there's other causes such as trauma. So the next cause is trauma when we might have lacerations and tears of either the uterus, the cervix, the vagina, anywhere around there which is obviously bleeding and needs repair. We can lose a lot of blood from that as well. Then there's tissue. So if the placenta gets stuck inside, or any clots or any other parts of the placenta that get left behind, the muscles again can't contract down very tightly, so that causes a problem, and until we've removed it, it can't contract down properly. And then you get clotting problems. So some women already have clotting problems that we know of that may cause the blood not to clot so well, and so that also causes bleeding problems as well. So they're the main things, and once the bleeding happens, we need to discover what the cause is so that we can deal with it effectively.
Yeah. So with what you've said, it's a bit scary to think that you, the individual, the mother having the baby, hasn't got any control whatsoever as to how it can be managed, because I mean you cannot instruct your uterus at that time to sort of contract or do it. So yeah, it probably comes across as a very naive question, you know. But then, how do we stop it from happening? Then there must surely be a way we can, something we can do to stop it from happening, isn't it?
So I think Karen will come on to how you stop it, but I'd like to state here that prevention is better than cure, isn't it? So if we're able to identify the potential risk of a woman ending up with a major obstetric hemorrhage, then you can plan for it. Okay?
Yeah.
So managing these cases starts during the antenatal period. So some of the risk factors will be some of the things that Karen has mentioned, but if you're anemic, for instance, okay, it means that already you're at a disadvantage. If, say, your hemoglobin, and hemoglobin, simply means your blood level, or your iron count, your hemoglobin level, if it's low, say you started with a hemoglobin of 9 or 10, the normal hemoglobin will be anything above 11.5. It means that already your blood volume is low. Also, if you're a very small woman, for instance, your blood volume, based on your weight and height and everything, will be small. So if you have a low hemoglobin and then you lose about 600 mils of blood, that might be quite significant for you. So during this antenatal period, any low hemoglobin needs to be managed and managed properly. So this is prevention.
Yeah.
So, you need to put them on iron tablets to help their blood levels to come to an optimal level before they go into labor. or you may have to sometimes transfuse them before they go into labor.
Okay.
And the transfusion can be either blood or iron itself, because some people can't tolerate taking oral iron. Karen mentioned the fact that the uterus might not be able to contract properly. I mean, in Ghana, of course, blacks, it is very common for us to have fibroids, isn't it? So having fibroids, for instance, is a risk factor. So during the antenatal period, when women have their scans, these things can be picked up, and then you plan accordingly. Yeah. There are some other causes like other conditions like what we call placenta previa. So the afterbirth is very low in the womb, almost covering the neck of the womb or very close to the neck of the womb, which can potentially bleed. During the antenatal period, you can pick up these things and then you manage it. One of the very important problems in Ghana, because of Jehovah's Witness, they don't take blood. In this country, when we identify such groups, we work with them. We explain things. They tell us what they want, what they don't want, and then we prepare for their labor. So when it happens, or by the time they hit the delivery suite, you have risk assessed them all, and you know that this person is at risk of having a major obstetric hemorrhage. This person doesn't. So that pre-planning helps, and I'm sure that is done in almost all hospitals in this world, and I hope it is, because without appropriate risk assessment, you will miss these things, and when they start bleeding, you might not be able to control it. But when it happens, Karen will take us through what we do to try and stop it from becoming serious.
So in terms of what the individual can do, it's mainly like prevention, antenatal.
Absolutely. So if you're not eating healthily during the pregnancy antenatal period, we encourage you to do that. Green leaves. In one of your programs, they talked about healthy diets. Green leaves, kwawunsusa. They contain quite strong iron. These are some of the things that we should be encourage them. And at the beginning of the pregnancy, you get your blood levels checked. You check for what your hemoglobin is. You check for what your blood group is. Halfway or maybe 3/4 way through the pregnancy, when you're about 7 to 8 months, 28 weeks thereabout, we check again what your hemoglobin level is, so that by the time you're coming into labor, we have a rough idea where you are, and then we can prepare and plan appropriately. So yes, moms need to do quite a lot during the antenatal periods with our guidance.
With our guidance. So now they've come in and they are actually having the problem of like postpartum hemorrhage or major obstetric hemorrhage. What happens to them?
Well, we call for help. Call for help very quickly. And to be honest, when we do our training, it's something that is very important, because in Ghana we know that they don't have automatic bell systems like we do. So one of our parts of our training is that we bring our own buzzers and call bells, so that we need to call everybody that needs to be in the room dealing with this situation as soon as possible, because the quicker you deal with it, the better. We talked about keeping the bladder empty, so one of the first things we do is empty the bladder. We empty the bladder so that there's nothing stopping mechanically that uterus from contracting down. We always lie the woman flat so that it keeps their blood pressure stable, because obviously their blood pressure might drop when they lose blood excessively. And we do what we call a uterine massage. So we actually massage the uterus, because that encourages it to contract. So you'll see midwives just rubbing on the uterus, and that helps to contract the uterus. Quite often if you stop doing it, the uterus relaxes again, and so you have to keep doing that while you're summoning all the help that you need. One of the things we use as a preventative measure when we manage labours is we use certain drugs. and we use drugs to prevent these kind of things from happening. Some women don't have those drugs, but generally most of our women are counselled to have a managed third stage of labour, so when the placenta comes out, so that it encourages these drugs, help to contract the uterus and stop any bleeding. And so if we give that as soon as the baby's delivered, we give that, and that encourages that to happen. And so most of our women in this country certainly have that kind of management.
Right.
If we needed further drugs, because there are other drugs we can use, we have another 4 potential drugs that we can use, which all do the same thing. They all are a different form of the same drug, which helps to contract that uterus. Some of them are longer acting, so they keep that uterus nice and contracted. And they're not very nice drugs, but they work quite quickly. They give us enough time to be able to control that bleeding. We measure the blood loss very, very closely, because it's really, really important that we know how much blood loss is happening, so that we can inform our anaesthetist and the people that are working with us, so that we might need to replace fluids or give blood as a measure that deals with that. So we measure it, we have scales, we measure every drop of blood that's lost, so that we can manage that very, very closely. We can also do something which sounds quite awful really, but we can do bimanual compression, which is something certainly out in the community setting we would have to do. It's not a drug, it's our hands. We've got our hands and that's all we can use. So we have to put a hand on top of the uterus and a hand inside the vagina, and it's a bit like pressing down on something. If you had a cut and you'd press down really hard on it, you're trying to stop the bleeding. It's the same kind of thing that we're doing. We're trying to compress the uterus and squeeze the uterus, so that we're causing that blood loss to stop, because you've got a big area where the placenta's come off, which is bleeding, and we're trying to stop that bleeding. And so it sounds very awful, but it's something that's very effective. And certainly if you're on the community, that's all you can do really. If you're out in a community setting, that's what the midwives do. So they're all the things that we deal with for a tone problem. Obviously, we look for trauma. If there's any trauma, we would repair it really quickly. We often have to take women to theatre to do it, because if somebody's bleeding excessively, we can't really see what we need to do. So we take them to theatre, give them very good pain relief, and then we repair whatever damage that needs to be done. And the other thing that we have is tissue. So if the placenta hasn't come away completely, we check the placenta. So we check the placenta, make sure that everything has come away, but it may be tiny bits of the membrane on the placenta or tiny little bits of the placenta. If they haven't come away, we need to then remove them. So that may be going again to theatre and making sure that all of that is removed, so that then the uterus will contract down properly.
Yeah. From what you are saying, I can easily say that it is something you cannot manage at home or manage without help. And that is where my worry is. And that is probably where the problem is for a country like Ghana or places where people delay in seeking help. How does the individual, like the mother who, because we do know from what you probably encountered, that people do have children at home. They have babies at home, and they don't always have the so-called, like professionals who are trained to do some of these things. Back in Ghana, I know we have traditional birth attendants, and all these people will be trying to help the woman. How much blood? I mean, how do they assess as individuals that I have had too much blood and I need to seek help?
Okay, so some of the simple things like rubbing a contraction, they can do that. You can easily train people to do that. That's a very easy method of something to do, which is not very, you don't have to be trained very much to do that. Assessing the amount of blood loss, I would say that if somebody is continuously bleeding, it's looking at the speed of the blood loss, certainly more than a few handfuls of blood. Clots often don't look as much, but obviously there's a lot of blood in those clots as well. We have, when we do our training, we have a diagram that shows you how much blood loss there is in different situations. So say on a cloth or on in a bowl, and how much blood loss that is, because it's very difficult for us to estimate how much blood there is. When you look at blood, it can spread out over quite a big area and look worse than it is, or we can underestimate blood loss. And so quite often the opposite happens. We underestimate how much blood there is, and especially if it's spread on sheets, on beds, on different places. So what we train is how to estimate that blood loss, and quite often it's better to overestimate, because quite often you can look at the woman and see what the effects are as well. And as Bright said, sometimes women don't need to lose very much to be clinically unwell, because they may have already got a low blood count, and so then it will affect them more. So certainly doing observations, pulses, blood pressures, looking at the woman and seeing the colour of their skin and seeing if they're sweaty and they're clammy, those kind of things can tell you how well or unwell a patient is as well. So I think looking at everything, not just the blood loss, is really important. But certainly if blood is continuing to bleed, that's a good indication that it's too much.
And to add to what Karen said, I mean, you've mentioned 2 different settings of delivery, community and hospital. So both of them, it is not something, as you said, that can be managed by one person. It's a teamwork. But maybe the team, you don't get that teamwork ethics that much in the community. If it's a traditional birth attendant attending to a woman, I think once the baby is out, I did say that the woman's body is very intelligent. So once the baby is out, your pituitary gland or the brain, there's something in the brain which tells the womb through the production of something called oxytocin. It's a hormone that tells it to contract. So most times women will be okay because the body is doing it itself. Okay? Animals in the forests, they do have babies, don't they? You know, there's no birth attendant there. They manage that naturally. So that is one thing. But once the bleeding gets beyond the normal level, that is where you start rubbing up the contraction, because you want to massage the uterus so that that natural contraction will start. Trying to get them to hospital in Ghana setting is a major challenge. And I think these traditional birth attendants do some really good work. When we met Mrs. Baumia, I mean, they were also doing some work up north, and I think it's spreading throughout the country, especially with the traditional birth attendants. They were giving them delivery packs, and I believe in those delivery packs there are some tablets called misoprostol. It is a tablet that once it's put in the back passage, it also helps with the contraction. So there are some really good work going on in the country, but we can do a lot more. Once they are in the hospital setting, or once this heavy bleeding occurs in the hospital setting, it is teamwork. And that is one of the things that when we go, we teach and preach. It cannot be managed by an individual person. Karen mentioned anaesthetists, midwives, the obstetric doctors. So everybody has a role to play. And if you train together as a team for such scenarios, once it happens, it's like clockwork. Everybody knows you do that, you do that, and then by and large we're able to arrest the situation.
Right. Yeah. So was it very different in Ghana, you think? Like from what normally happens here?
Yes. I mean, to start with, if somebody started bleeding, they do not have an alert system. I'm sure with time this will catch up, but they will potentially call out, scream and hey, somebody's bleeding, and then people will gather around. But when people gather around, do they know what they are doing? Everybody needs to be given something to do. And I think in one of the videos that we showed the other time, we had this person who was bleeding, and he had a whole team around. So if they're able to call for help, which is standard, but when people get there, the ability to do what needs to be done. So you do this, you put in a line in, anaesthetist does that. That teamwork approach, that teamwork ethics is something that when we go, we preach.
You preach.
Yeah.
Right. Okay. So obviously we've got two topics today. So I don't know whether we want to go straight to preeclampsia, eclampsia, because these are all major topics on their own. We are trying to sort of put together and then come to a conclusion with how to manage both these situations. So can we go into eclampsia as well?
But before that, the other thing that we also do in this country is the PPH pack. You want to talk about that?
When we have equipment that is set up for our emergencies, so it will apply to the preeclampsia as well, because we know that in an emergency we need everything ready and waiting for us, because it's the time that it takes to set things up. So we have a pack. We have a pack with everything in it that you need to deal with the immediate situation, and all we have to do then is grab the drugs, grab the pack, take it straight to the woman. And same on community, they take out their equipment. The same with preeclampsia as well. We'll go on to talking about that, but we have a pack and we set out this pack, and that's what we use for our training, so that if we use it for our training, we get used to using it, so that we then know that this is what we're going to use in practice as well. And the more you lessen the time that you have to run around looking for things, and you keep all your staff in the room dealing with the emergency, it makes it much more effective treatment. So that's certainly one of the things that we have improved on our areas really in our management.
So it's the same kind of preparation you are trying to...
Yes, we've got things ready. We don't have to run around looking to go in different places to get bits of equipment. We know exactly where we need to just pick it up from, take it straight to that place.
Did you send some of these packs to Ghana?
We've certainly talked about how they make them up, and we've used them for our training, and suggested that certainly when we have these boxes or a pack, and certainly in some of the places we've been to, they did have those packs because we saw them when we went back again.
Okay.
Wenchi Hospital.
Yeah. So they had these packs labelled so that people know where they are, and you just go and pick up that pack and you use it for that emergency, and it makes things far more efficient.
Right. And the belief system, are they following?
Not yet.
Not yet. Okay.
Not yet, but I think it's work in progress.
Work in progress.
I think it's work in progress. And the other thing that I wanted to talk about is getting blood is not easy. In this country, people donate blood quite a lot. Our blood banks are reasonably well equipped. I mean, quite recently I went to voluntarily donate blood. It is something that can be encouraged more in Ghana, and I'm sure they do it. But when you have a major obstetric hemorrhage, we are talking about liters and liters of blood loss, which needs to be replaced quickly. I know Ghana has the cash and carry system. So you pay and then you get sorted. So maybe that is one of the stumbling blocks. But in an acute emergency, it is my hope that they are able to get the blood that they need. It is not just 1 pint or 2 pints of blood. In the severe hemorrhages, we are talking about 5 liters blood loss. You have to replace the blood, and it's not just blood that you are replacing. You are replacing blood products, certain things in the blood that helps the system to function properly, like platelets, cryoprecipitates, fibrinogen. These are things that help the blood to work properly, to clot. These are some of the things that needs to be replaced. So when you lose about 40% of your blood volume, that is where the trouble starts. So everything that we do is to try and stop you from getting to that point where you've lost so much blood that trying to reverse it becomes almost impossible. And that's what we call DIC. We don't want to get into that stage of disseminated intravascular coagulation. Yeah, so yes, you can give all the drugs, and sometimes you can even open up, do surgery, stitch the womb and all those things. But the amount of blood that you've lost needs to be replaced. So every unit, every hospital needs to look at where do we get blood from. And it's not only for obstetrics. Obstetrics does take a lot of hospital blood and also accidents and emergency because you get trauma. Yes. So every hospital need to look at how do we get enough blood in our blood bank for our mothers and for our trauma patients. That we will leave it for the individual hospitals to sort out.
Because I mean, from previous experience, I know once you go in, then all your family members have to probably line up
come and give blood.
to give blood.
Yeah.
Isn't it?
Yeah.
And that can't be good enough. Yeah, because obviously if they don't match, then all that,
Yes.
all the problems to do with it, it
Yeah.
must be readily available,
Yeah.
ready for use.
Yeah.
Yeah.
Right. Okay. So can we go on to eclampsia? What is it? We hear that a lot. Eclampsia, pre-eclampsia.
Right. So eclampsia is when you have such a high blood pressure in pregnancy that leads to fitting, okay, or what we call convulsion. Now, it is an aspect of hypertensive diseases of pregnancy. So it's a very wide umbrella, hypertensive disease of pregnancy. And hypertensive disease of pregnancy complicates about 10% of pregnancies. So if 100 women get pregnant, 10 of them would develop some degree of hypertensive disorders of pregnancy. Now, out of this 10%, 80%. So the 10 out of 100 will get it. Out of that 10, 8 of them would have experienced high blood pressure for the first time in their life.
Okay.
The other 2 would have had a background history of high blood pressure even before they got pregnant. So there is, if you mention preeclampsia or eclampsia, they are a type of hypertensive disorders of pregnancy. So some women will start the pregnancy with a high blood pressure. They may have had it unknowingly before they got pregnant. And that tends to manifest in the first 20 weeks of pregnancy. So we're talking about 5 months of pregnancy. So if you see a woman, if you're in the community or in a hospital setting, you see a woman, you check her blood pressure and it's high within the first 20 weeks of pregnancy, she may have had hypertension before she got pregnant.
Okay.
And sometimes you don't know. Hypertension is a silent killer. As I said, some will also experience hypertension for the first time in their lives. And this is what we call pregnancy-induced hypertension or gestational hypertension. So they are okay. They never had high blood pressure. Pregnancy happens. Everything goes well. Then after 20 weeks, their blood pressure begins to go up. Now, these 2 can gradually generate into preeclampsia. So we are talking about high blood pressure in pregnancy, which is such that it is beginning to affect certain organs in your body. So that is preeclampsia. So your blood pressure is very high. It begins to affect your liver, your kidneys, and some other organs in your body, and even the brain or the neurological system, and then it begins to affect the baby as well.
Right. Okay.
So preeclampsia is a syndrome. Okay?
Right.
Now, if that is not managed or if that is missed for whatever reason, then that can then develop into severe preeclampsia. And that is where potentially these women will start having convulsion. And I always say this story. When I finished medical school and I was going to do my house job in my favorite hospital in the Obs and Gynae department, this was the first day, a very green novice doctor. I walked onto labor ward and there was this woman on the floor fitting. I didn't know what to do. That was eclampsia. Okay, so eclampsia is the extreme form of preeclampsia. where they start fitting.
Yeah.
So when we say hypertension, we are saying high blood pressure. Okay. We need to know why these things happen. It is very complicated, and we can probably take about 3 days talking about it.
Mm-hmm.
How it actually happens, it's multifactorial. So we believe that it is a disease of the placenta, the afterbirth. Okay?
A disease of it.
A disease of the afterbirth.
Okay.
It could also, there might be a genetic component to it as well as an immune component. But the most popular theory is that it's a disease of the placenta. So this is what happens when you get pregnant. The fertilized egg moves through the tube and into the womb. Okay? It cannot live there independently. It will have to be dependent on mother's blood to be fed, to receive nutrition and oxygen.
Yeah.
So it sticks itself into the wall of the womb, and its blood vessels will connect with mother's blood vessels. And for it to do that, there's something called syncytial trophoblast. So the cells of the placenta, or the baby, or the placenta which is forming, the cells will invade into the maternal blood vessels. Specific maternal blood vessels is called the spiral arteries. So these are arteries which are going into the baby, and then the baby invades into it. And what it does is, it makes the resistance in mom's blood very, very low. So if the resistance is low, what it's doing is that blood is able to flow freely to the baby. Okay?
Okay.
And also, it makes mom's system very resistant to chemicals in our body or hormones in our body that causes blood vessels to contract. Okay, so that's establishment where mom's blood vessels within the womb becomes low capacitance or low resistance. That helps blood to flow freely to the baby. If that doesn't happen, as I've said, then it means that the mom's blood vessels, the resistance in the blood vessel is high. So nature will say that, okay, I need to feed this baby, don't I? But the blood flowing through the vessels are going against the resistance. So my blood pressure then has to go up in order to push the blood to the baby.
Right.
So this is just explaining in a lot more layman's terms so that people will understand it. So that is how preeclampsia happens. That means that the only treatment will be to get that placenta out, isn't it?
Right.
So
okay.
we will come to that later on. But we said it complicates 10% of pregnancy, or up to 10% of pregnancies. So why will mother A, B not have it, but mother C will have it? Okay, because we all have, when we get pregnant, there will be placenta, or there will be a baby, there will be a placenta.
Yeah.
So how come that certain women do not get it and some do? Again, we come back to risk factors. Okay, so there are high risk factor groups. So a woman who's had preeclampsia before, for instance, is up to about 5 times more likely to develop it again in a subsequent pregnancy. If you have a kidney disease, for instance, already there's a vascular problem. If you have diabetes, if you have certain types of diseases like autoimmune disease, SLE, systemic lupus erythematosus, these are high-risk groups, so they are more likely to develop hypertensive disorders of pregnancy. But also, interestingly, if you're a first-time mom, you are at risk.
And what is the reason for that?
Your body has not
Never
been
experienced.
subjected to the pregnancy hormone, so literally your blood vessels are quite rigid, resistant. So a first-time mom, especially teenagers, or when you hit the age of 40 and above and you become pregnant, you know, already your blood vessels are gradually becoming rigid already. If your BMI at the beginning of the pregnancy is on the higher side, and I wouldn't like to use the word fat because women don't like that, but if your BMI, you're a larger woman, you are at risk. And a family history of preeclampsia, you are at risk. So you can see that there are a combination of factors. So this can be your first pregnancy, you are aged 40 and above, and Ghana, our women, they do have babies after 45, and then you're obese, you are at a high risk.
Yeah.
Okay, so these are some of the risk factors. So when we say hypertensive disorders of pregnancy, it is high blood pressure in pregnancy, which can potentially affect the organs, including the baby. How does that affect the baby? If the baby is not getting enough nutrition, what will happen to the baby? Baby is not going to grow well. So baby will be a very tiny little thing, mom may end up having a cesarean section, prematurity, because we need to get this baby out of that environment quickly before something happens to the baby. And indeed, it can kill babies whilst in there.
Right.
So that is also another major headache in Ghana, and it's probably the second commonest condition that causes maternal mortality in Ghana, about up to anything between 50 to 20%. Whereas in this country, it's less than 1 in 100,000.
Yeah.
So we screen them, we pick them up, and then manage them accordingly.
So what I was going to say is I'm putting myself in the place of a young woman who wants to start having babies and worried about preeclampsia, eclampsia, and then hemorrhage, because I'm sure my daughter is watching and she'll probably be thinking, oh my God, is that all to expect and all that?
It's a bit scary, isn't it?
It is scary. And is there anything that the individual can do? Because my focus in doing all of this is to make sure people are well informed and can do something about the things they can do something about. So Karen, is there anything like you can do even before?
Definitely we risk assess. So one of the really important things we do is when we take histories from pregnant women when they first become pregnant, we look at their risk factors. Even before that, they could go to the GP and ensure they are healthy enough. Not many people tend to do that, but we do recommend that people go to the doctors and just make sure they're healthy before they even think about getting pregnant.
Yeah.
Doesn't often happen, but then when they come to us and we see them, we can do a full risk assessment. We take a very long time going through their medical history, their family history, looking for all the risks that might be there already, and then we can advise them. So it may be diet, it may be smoking, it may be weight loss and things like that. And certainly with family history, we could monitor them more closely as well. So with some of these high-risk pregnancies, we would certainly be advocating very close monitoring of blood pressure. And we do that antenatally. We bring them in for regular checks. And if there's any suspicion of anything like that happening, we may scan the babies more regularly. We may monitor the babies as well as the mums so that we can look for anything, certainly with blood tests and things like that, to see if there's any changes whatsoever. If there is, we often bring them into hospital. We can manage the pregnancy. We might induce them early. All sorts of things that we can do on the way through pregnancy. But certainly if we pick up anything, we'll be monitoring them very, very closely, looking out for any signs. But I think the other thing to say is that women often feel very well when they have preeclampsia.
They
don't feel unwell. Quite often throughout that period, they can come in and they don't know that they're unwell. So it can be something that is very hidden. We can tell them about the signs and symptoms, and later on when it gets worse, they certainly do get signs. So they can get signs of like dizziness, pain, epigastric pain, so the top of their abdomen they can get pain, they can get headaches, they can get all these symptoms, visual disturbances, they can even get flashing lights, they see flashing lights and disturbances. All those kind of things give us a warning that something's happening, and we can educate women on what to look for, and certainly to get assistance if any of those things happen, and we advise them to come in and be checked. Yeah. And then we will ongoingly monitor them until they deliver.
And to add to that, it is because it's such a serious condition. What we will say is that women should take it seriously. If you want to get pregnant and you know your BMI is high, start working towards it and bring it down, because it's not only hypertension in pregnancy, it can also lead to diabetes. So optimize your weight, before you get pregnant. Let's say, sometimes we don't plan pregnancy, do we?
No.
I'm a 41-year-old woman minding my own business. I've had 2 babies. The first one was preeclampsia. The second one was okay. I decided not to have any more babies, but boom, I'm now pregnant. We can assess you, as Karen said. If you fall in the high-risk group, what we do in this country and what the recommendation is now worldwide is to start them on aspirin. Okay. So once they get to 3 months, 12 weeks, you give them aspirin tablets.
What's the reason for?
So 150 milligrams. So aspirin is an antiplatelet. So it thins the blood. Okay, and once the blood is thinner, it's able to flow freely. Okay, so we put them on aspirin from 12 weeks onwards all the way to when they get to about 9 months, 36 weeks or so. Okay. So that is one thing that we do. The second thing that we do also is, if you fall into that category of high-risk women, there's a special type of scan which is done, uterine artery Dopplers, they call it. They're able to detect something in the blood flow in the uterine artery, so the artery that is supplying the uterus. And if there's a notch, they call it a notch, it's a sign that potentially you might develop preeclampsia or hypertensive disorder. And then we have to follow you and the baby very closely. And the midwives do really fantastic job. They will check your blood pressure at each visit. They will check your urine. That is done in Ghana as well. When they check your urine, what are they looking for? They are looking for the presence of protein in your urine. Remember, I said it can affect every organ in your body. So once you start developing protein in your urine with high blood pressure, that is the definition of preeclampsia. So each visit you check your blood pressure, and then you get your protein check as well. Quite recently, from the medical point of view, there is a blood test that can depict whether you will potentially develop preeclampsia in the next week or 2. Okay? So if I saw you today, for instance, in my clinic, and you gave me some unusual signs and symptoms, Bright, I've been having some headaches and some visual disturbance, but I checked your blood pressure and it is okay-ish. And we checked your urine, maybe just 1+ of protein in your urine. We're able to do this placenta growth factor. It's a type of blood test. If it falls within a particular range, it's indicative. Anything more than 38 is indicative that potentially you will be developing preeclampsia. And when that's the case, then we do more close monitoring. So it shouldn't put people off getting pregnant, but optimize your body function and your body system before you get pregnant. If you cannot do that, that's fine. But during pregnancy, you have to be very vigilant, and you have to report all the signs and symptoms that Karen talked about to your midwife or to your doctors. And to the doctors, these things need to be checked at each visit, because antenatal care is all about risk assessment. You pick up the risk and then you manage it.
Right. Because you mentioned aspirin, I think I'll take you back to that, because I know from the background we come from, people like to self-medicate. And especially when COVID started, they heard about taking aspirin and taking all sorts just to, and COVID is dealt with.
Yeah.
You know, every answer is in the drugstore. So let me take you back to that aspirin. Is it something every pregnant woman will say, oh, okay, I heard it on the show. They said you can take aspirin and it's a solution to all our problems. Is that what you were saying?
A word of caution.
Yeah.
You just can't get up and start taking aspirin when you're pregnant.
Good.
This should be done in conjunction with your doctors. This should be a doctor's advice. You should be categorized into a high-risk group before you do that. Okay, and it's not only aspirin. Sometimes we have to, if there are some other risk factors, we give you blood thinning injections, you know, like Clexane and Tinzaparin. So you just don't get up and start taking aspirin for the sake of it, because there's also a risk of taking aspirin. It can be associated with one of the causes of antenatal blood loss or hemorrhage. It can cause, it's associated with abruption. So please, the use of aspirin should be directed by your doctors, and the doctors will be monitoring you. So don't just get up because I have a BMI of 35, this is fine. My first time pregnancy, straight away I go and take aspirin.
Yeah.
Even the use of aspirin, the recommendation is after 12 weeks. So try not to take it, or it shouldn't be prescribed or taken within the first 3 months of pregnancy. It's after the 12 weeks. So that was a really good question. Don't just get up and take it. It has to be under guidance.
Because I know that it's a habit. I mean, visiting the drugstore is like, oh, there's solutions to all the health problems that we can ever encounter. So that was of particular importance to me, because people are definitely going to be on the case of aspirin as soon as we finish this, because we mentioned
people do it here as well. They self-medicate a
off
lot.
the counter. But I think it's on a different level.
Be safe. You've got to be safe. Yes, I know.
There are mini doctors. You know, you go to the drugstore. There's a doctor there. There's a pharmacist. There's everyone that you can think of. All the specialists are in the drugstore.
Yeah.
So I wanted that to come out clearly, so people don't start self-medicating.
Absolutely.
If you've joined us, we've been looking at some of the causes of the high morbidity and mortality rates that are faced by developing countries, mainly because in most of the developed world, these things are managed and people work in teams to bring solutions. But what we are trying to do through the Trowbridge Foundation is to try and take the culture of working in teams to solve some of these problems, isn't it? That we have identified back home. We haven't quite exhausted eclampsia yet, you know, and preeclampsia yet. So I have been diagnosed with eclampsia or preeclampsia. Is this something that I can have with every pregnancy, or do you expect to have it once you have the first pregnancy, eclampsia, then it means all your pregnancies you have eclampsia or preeclampsia, or it doesn't really work out that way?
As I said, having eclampsia, that predisposes you to another eclampsia in subsequent pregnancies. So you are up to about 4 to 5 times risk of developing preeclampsia again in your subsequent pregnancy. So when you get pregnant, if you've had a background history of eclampsia or preeclampsia, or even when you have a family history, a close family history of preeclampsia, it means you're at risk. And as I said, it shouldn't put you off trying to expand your family, okay?
Yeah.
You do it, but because you are known to have it, and because you have had that predisposition, we're able to, number one, as we said, start you on aspirin do the necessary investigations, including scans,
Yeah.
to check whether you are more likely to develop it again or not. If you've had one preeclampsia before, it doesn't mean you will always have it in your subsequent pregnancies.
Okay.
When we talked about the risk factors, we said first-time moms. So those who've had more babies, they are less likely. So yes, you are at risk of developing it again, but chances are you will not, especially if we put things in place to try and prevent it. And
Right.
aspirin is one of them.
Yeah. So people don't have to be too scared that
No.
they've had.
No.
Yeah, because it can be life changing, isn't it? If it's not well
Absolutely.
managed, then it may put people off
Yeah.
even having
If people
More
get
children.
scared of having babies, the
the
world, the end of
population.
the world.
Yeah, management. How do we manage it?
It's very much drug related when we manage it. Again, it's a very quick thing. We have to do this as a team, but very, very rapidly, because we need to administer the drugs literally within a few minutes. So a lot of the preparation is done by making up drugs. We have to make up a drug solution which we give.
Okay.
We also manage the blood pressure, so we give drugs to control the blood pressure.
Is that in labour?
It can be in labour,
Labour.
it can be pre-labour,
Pre-labour.
and it can be in
Anytime.
labour. So any time, but certainly if you've got to eclampsia where somebody is fitting, certainly we give drugs by infusion very, very quickly. One of those drugs will be an antihypertensive to bring the blood pressure down, or to at least control it within a controllable level.
Yeah.
The other drug that we give reduces the irritability of the brain tissue so that it settles, it doesn't get rid of the fitting, but it can settle things down. And both of those drugs are given very, very quickly
Yeah.
by infusion. When we do our training, we practice in real time drawing up these drugs, because they can take a little bit of time to draw up, and quite often there's so much else going on at the same time that two people really need to concentrate on just doing the drugs. So when we do our practices, we actually have fake drugs that we use, and we actually draw them up in real time so that people have an understanding of the time that it takes to draw these drugs up, and that they can concentrate on doing that. They learn the dosages, because obviously it's not something we do all the time. So we practice the dosages, and we give, again, people roles to do. It can be very important, just like anybody that's fitting, that we make sure their airway is clear, we make sure that they're safe. So we make sure that they're safe, and we always call an anaesthetist to help us as well, because we may have to obviously look at their airway, make sure they've got oxygen. We don't, in these kind of emergencies, the mum always comes first. So people think that we might be worried about the baby. Of course we're worried about the baby, but we don't do things like monitoring the baby at that point in time, because we want to make sure that we resuscitate the mother, because in turn that will help the baby. So we need to make sure the mother is good and safe before we even think about listening to our baby and making sure that our baby's okay. So quite often I think people and families quite often get worried because we're not taking much notice of what's happening to the baby inside.
Yeah.
But we very much deal with the mother first, and in the other circumstances as well, make sure the mum's resuscitated first and that she's stable, and then we deal with the baby.
Yeah, there are a number of interesting questions from those who are watching online, and that is what we really appreciate
Definitely, yeah.
the most, the questions from those watching. And there is one saying, let me start from here. Alberta Kukwa Brew is saying, can they talk a bit about sharing medications? Example, my friend was given a particular medication during her pregnancy and she had a healthy baby. We are the same type. I don't know what she means exactly by the same type, whether blood type or I'm not sure about the type. Alberta, you may have to give me a bit more information, but I'll carry on with the question. We are the same type. Why can't I get the same medication and forget multiple antenatal trips?
Right. Okay. So when you have preeclampsia, or when you've been diagnosed with any form of hypertensive disorders of pregnancy, mainly pregnancy-induced hypertension and preeclampsia, It depends on how high your blood pressure is. We start treatment when your blood pressure is, 140, above 140/90. Anything below that, we just monitor you. Okay. Now, I'm not sure what Kukwa said about sharing, but one of the things that we really do our best to stop women from doing is sharing medications. Okay. If this medication works for me, it doesn't mean it will work for Karen. So Kukwa, we will really persuade you not to share medications, but there are safer drugs out there that helps to control blood pressure. Beta blockers, some other types, and some of them are quite cheap. God being so good, the antihypertensives that we use are not that expensive. But there are 3 main ones that are used during pregnancy. But as I said, we cannot share between patients, because what will work for me will not work for Karen. Your doctor needs to give you one particular one, monitor you, and make sure that you are responding to that medication before you switch to a different one. So there is treatment for sure, but I have said that the final treatment for severe preeclampsia, eclampsia, and eclampsia is delivering of the placenta. So once the placenta comes out, preeclampsia and eclampsia tends to get better and better and better. So delivery is the final outcome.
Is the final outcome. An interesting question from a man watching. That's made my day when men are watching these programs, because obviously they put us in that state to get all these complications.
It's our fault.
It's certainly their fault. So Eddie Boachi Apple, grateful you are watching, and he says, please, can preeclampsia lead to epilepsy? I think it's the fitting that sometimes,
Epilepsy is completely different kettle of fish.
Different thing completely.
Okay.
But to look at it, a fit is very similar to an epileptic fit, but it's not the same thing at all.
It's not the same thing.
Not
so can we just highlight a bit? And I'm saying this because, like, back home, when anyone is having a fit, no one gets to them to help them out because they think epilepsy is infectious, and so you can imagine that happening to a helpless pregnant woman who is fitting and needs help.
Okay, so the reason why we're saying it's completely different is eclampsia. It's a type of convulsion or fitting which only happens in pregnant women. If you are not pregnant, you will never get eclampsia. If you are a man, you will never get eclampsia because you can't be pregnant. But the way they present is the same because it is affecting the brain. The brain has become irritable. Okay, so the brain waves is gone into overdrive. So the way they shake is the same as epilepsy. So epilepsy can happen in pregnancy, but you realize that the woman has a background history of epilepsy even before she got pregnant. So these are 2 different things. Eclampsia is only in pregnancy.
All right.
Because the problem is the placenta.
The placenta, right. Okay, and then another question from my big sister. She's always a fan of this show, watching, and she says, does the aspirin, and Stacey Amond, she says, does the aspirin intake not have any adverse effects on the unborn baby?
No.
No.
The answer is no.
Is it?
Yes, it's very safe. Aspirin is a wonder drug.
It's a wonder drug.
It's very safe.
I hope you heard.
Don't everybody take it.
Yes, but it has to be controlled. But when you get to 36 weeks, which is 9 months, we stop because we are preparing you to have your baby. Okay? Remember that the aspirin is only to try and prevent it. It may not prevent it completely. It may delay the onset. But by 36 weeks, baby is fully grown. If we have to deliver you, we'll deliver you. So it is a very safe medication, just like the other antihypertensives that we use. We use the safer ones.
Okay, right. So somebody will be thinking, okay, we are discussing eclampsia, preeclampsia, hemorrhage. How does the community get to identify some of these dangers? You know, they are the reasons why we are doing this. So it's important for us to reach them with very, very basic information that will just pinpoint that they are in danger, seek help.
It's true education, isn't it?
I think one of the things is that we've talked about transport,
And
getting help,
yeah.
getting to help. If somebody had a fit at home, the most important thing is to protect their airway, make sure they're safe and that they don't injure themselves while they're having the fit, and then to get them to medical attention as soon as possible. Because, as we've said, you need drugs, you need medical attention to be able to treat that condition. You can't treat it at home. So you just need to make sure that that person is safe to transport into hospital. The same as if we have somebody that fits on one of our wards, we can't move them to, say, our labour ward until that fit has stopped. They don't last very long, the fits. So once the fit has stopped and the woman's safe, we then bring her to an area where we can treat her with drugs and medication. But the same with any of these things, we monitor them very closely. So if they're out on the community, any sign that the blood pressure's rising or they're having any symptoms, they should be referred for medical assistance and then they can be monitored. So it's picking up those things very early on and making the women aware of what to look out for as well, so that they know that this is not right and they need to seek attention to make sure that it's monitored properly.
It's all education, isn't it?
Yeah, definitely.
Education at all levels, and
Yeah.
And I believe they do that.
Yeah.
Definitely in Ghana. And you know, there are some classical symptoms of, you know, preeclampsia or high blood pressure in pregnancy. And as Karen said, headache, visual disturbance, so you feel a bit dizzy, you have excessive swelling, you have pain in the upper part of your abdomen. These are some signs that when you get them quickly, you need to seek medical advice.
Right. So as we draw the program to sort of a close, anything else we want to add on that we've missed out on, either hemorrhage or eclampsia, preeclampsia?
I think with the hemorrhage that we talked about at the beginning, one of the things that we missed really for the community is that mums can breastfeed. Breastfeeding quite early on helps to contract the uterus. So it's something that when the blood loss is starting to get a little bit heavier, but it's not really excessively heavy, putting the baby to the breast can actually release these hormones that we've talked about, this oxytocin, which helps the uterus to contract down. And quite often mums, when they breastfeed, they feel pain in their tummy where they're feeling these contractions. And so that is a good thing to do if they think the bleeding is a little bit heavier than it should be. Put the baby to the breast and start breastfeeding, and that will help. And it's a very simple thing that can be done very early on in the community at home.
And they do better in Ghana, don't they?
Yes, and they do it much better in Ghana than they do in England.
There's something we are doing better than
you do it
other places,
fantastically.
isn't it?
Exclusive breastfeeding.
Yeah, so some of the feedback coming through, awesome as always. And I had the lady who presented on or came to share her experience, Harriet Brown. She says very informative, and you guys have done a very amazing job as usual. Alberta Brew is saying that is why it's important for a girl to become a woman before becoming a mother. Obviously, that is important. Or is it any easier? Any advantage,
it's not
disadvantage?
easier, but it's a lot more knowledgeable. If you get the knowledge, you prepare for something.
Yeah, definitely. And Harriet again says life-saving information given for free, and that's all our aim. We are all aiming towards the same thing. Odofo Kai Naughty, not sure whether I've said it right.
Odofo Kai Naughty.
Oh, you know, the person says our youth need to hear all this. Our youth need to hear all this, and all this is from the Childbirth Foundation. They are not just here in the UK criticizing what is going on in Ghana, but they are actually going with solutions and helping them have that sense of teamwork, isn't it? Yeah. So, yeah, anything else you would want to add?
I think we've always said that we, as a charitable organization, we do need the support from the community and the people in the diaspora. Some of these things that we purchase to send to Ghana for training, these mannequins, for instance, what we are looking at is potentially buy a mannequin which is quite specialized. It can fit. We've got mannequins which can simulate bleeding.
Yeah.
These are things that in future we'll try and get to, support the training that we give. It's not 100% necessary, but it's brilliant if we have it, and that is something that we're working towards.
Yeah.
And when we go to Ghana, it's all people's charity that they support us, and we'll just encourage people to do that.
Yeah, and we really want people to support, and that is why we want to keep doing this and looking at every topic that we can think of, which will be to the benefit of people. So, unless there is no more to add, let me acknowledge a few people who always spend time to watch. Ifwa Amen is watching. Ikuya Danswa, Jane Siri Vivian Yotega. You all watch this program religiously. Thank you, and keep sharing and encourage others to share so we get the knowledge to people. Evelyn Asiedu, George Noelate is watching as well. And you guys have all been brilliant. So I'll allow Dr. Bright Jampo and Mrs. Karen Billington just to round off if there is anything else. Yeah, but we want to encourage people to support all these foundations so we can get the good works out to the people who need it like the most. Because obviously here we are supported by the NHS that does everything. Back there, it is not exactly the same, isn't it? And very important, if we can do anything at all, we keep going with the efforts that we've started. Yeah.
And what I'll say is we will carry on doing these educative programs. When we come to Ghana, we will be going to some radio stations to
definitely
do some more health education, and hopefully people will continue to support the good works that we're doing. Yeah.
And then we have to share your website and all the links that we need people to. So not just waiting for like our birthdays to do the fundraiser for our birthdays. That helps, but once the day passes, I've noticed people don't even go on there again. So any way we can let it keep like in the minds of people, we will still keep doing that. So in the absence of anything, or Karen, do you want to say anything?
Just to reiterate that we want people to be more informed. We take our knowledge and we share it. We're not about telling people what they should or shouldn't do. We're sharing good information and just making sure that people are more aware of these conditions, because the more knowledge you have, the better you can deal with things and the safer we'll be.
So people should look out for the next few topics, which might include diabetes in pregnancy and COVID infection in pregnancy.
I can't wait for that one, actually. So I was going to say we have to keep this going. It is just the beginning of many more topics. And some of the feedback that came through from your very first session was, can we look into women's health generally, because like a lot of people are suffering with fibroids, and one that a lot of people highlighted was menopause.
It's something that's very
big
in press at
because
the moment,
I'm sure a lot of my viewers are probably within my age group, and I think are probably struggling with menopausal things, and so they are very keen. So that kept coming up. So I thought I should bring it to you, so we think about we can probably even mix some of the problems to do with women as a whole, and then we can carry on with some of our series. But the COVID one, I'm looking forward to that. So can we safely say we can do sepsis in pregnancy, and then we look at COVID? for instance, and then we can take other topics along, probably menopause on another date as well. But all too soon we've come to another very, very informative session, and I honestly and sincerely can't thank you enough, Dr. Bright Jampo and Mrs. Karen Billington, and for taking time. You've all been working all day, you're all on call, and yet you've taken so much time to travel all the way from Luton to do this. So I am really, really appreciative of what you have done and what you continue to do. So viewers, if you're watching, please keep sharing. Let's get the message out there. Let's get people involved. Search for Trowbridge Foundation online and see some of the activities that they are doing in Ghana, because I plan to join you in a whole lot of activities that you have coming up. In 2 weeks' time when we come, I am expecting a mother and a son who have decided to come and talk about living with sickle cell disease. And that is what we are doing next, living with sickle cell disease, and talking to them. I'm just so inspired by what I'm hearing, because obviously mom is of a very good age. I would not give it away. But she must have looked after herself so well, and has managed to convince son to come with her to do this. So we'll have a touch of everything, modern and whatever. So I'm looking forward to that one. This has been Let's Talk About Health, and it has been another awesome session, and I'm looking forward to the session in 2 weeks, like I said. But before we do, please take care. COVID is still on the rise, but support Trowbridge Foundation. Donate. Nothing is too big or too small, but you will be saving lives. You'll be helping people, not just in Ghana, because we will probably expand, all the activities that we are doing. So thank you once again for coming. Keep sharing. Thank you. God bless. Bye.
I have known Chris over the last 5 years. He was my personal assistant some years ago. What I can say about Chris is he's very hardworking. He's meticulous, very detail-minded. He likes to think outside the box. You leave a work to Chris and you are sure you'll come back to meet your best. And we were working together nicely before he had this intention of starting his own business. He discussed it with me and I endorsed it, and I let him go. And ever since I've been working with him, I disposed a couple of properties. I did it through him, and that was done in a record time. And I will always recommend Chris for anyone who wants to deal with properties, to deal with Chris and have the peace of mind and also have assurance that he will have the best deal.
Christian is a hard-working, focused young man who will go all lengths to achieve results. We have worked with him for some time now, and we will recommend him to anyone who wants to buy a land. If you want your valuations done on your land, he's the best man. If you need land title documents done for your company, I would recommend him to be the right person to do so. In the near future, if I want to buy a land again, I will go for Christian, and I recommend you to do same.
At World Remit, we understand what the journey is about, how it can sometimes take a little distance to bring us a little closer together. With ways to save more when you send more, World Remit is here for you so you can be there for them.
I have known Chris over the last 5 years. He was my personal assistant some years ago. What I can say about Chris is he's very hardworking. He's meticulous, very detail-minded. He likes to think outside the box. You leave a work to Chris and you are sure you'll come back to meet your best. And we were working together nicely before he had this intention of starting his own business. He discussed it with me and I endorsed it and I let him go. And ever since I've been working with him, I disposed a couple of properties. I did it through him, and that was done in a record time. And I will always recommend Chris for anyone who wants to deal with properties to deal with Chris and have the peace of mind and also have assurance that you have the best deal.
Christian is a hard-working, focused young man who will go all lengths to achieve results. We have worked with him for some time now, and we will recommend him to anyone who wants to buy a land. If you want your valuations done on your land, he's the best man. If you need land title documents done for your company, I will recommend him to be the right person to do so. In the near future, if I want to buy a land again, I will go for Christian, and I recommend you to do same.